Welcome back. My name is Dr. Conwell, and this is Module 3, the final module of my three-part series on the deep tendon reflexes. In Module 1, we built the foundations. We defined what a deep tendon reflex is and its physiological purpose. We placed it within the neurological examination, and we worked through the anatomy of the reflex arcs, the myotatic stretch reflex, reciprocal inhibition, and the inverse myotatic reflex. In Module 2, we moved from anatomy to assessment. We examined the physiology that drives the reflex, conduction, synaptic speed, and descending control. We identified the spinal cord levels behind each reflex you test. We introduced the grading scales, and we began to interpret what a reflex is telling you. Module 3 is where the science becomes the skill. We will study the neuropathology of the reflex, how and where the arc fails. We will contrast the upper and the lower motor neuron lesion until that distinction is second nature. And we will put the reflex hammer in your hand, the technique, the protocol, and the errors that mislead you. Here is the promise of this module. By the end, you will be able to take any reflex finding, brisk, absent, or asymmetric, and translate it into a confident statement about where the lesion lives. Let's begin. This slide is the map of the whole series, and I want you to see where today sits within it. Module 1 was foundations. We defined the deep tendon reflex, placed it within the neurological examination, and built the anatomy, the myotatic stretch reflex, reciprocal inhibition, and the inverse myotatic reflex. Module 2 was assessment, the physiology that drives the reflex, conduction, synaptic speed, and descending control, the spinal cord levels behind each reflex you test, and grading. A word on grading, because you will meet two scales and you need to know how they relate. The NINDS scale, 0 to 4, is the board standard, proposed in 1993 and validated for inter-rater reliability. That is the scale to know for examinations, and we will return to it in Chapter 10. The Wechsler scale, 0 to 5 plus, is the clinical shorthand many clinicians still use at the bedside, where 5 plus denotes sustained clonus. Same phenomena, different ruler. Read each grade as it is written on the slide, and when you chart, know which scale you are using and say so. Module 3, today, is clinical application, neuropathology, the upper versus lower motor neuron distinction, case studies, and the examination itself. The goal is simple to state and demanding to achieve. By the end of this module, you should be able to translate any reflex finding into a confident anatomical localization. Here is the path today's module will take, in 3 chapters. Chapter 8, Neuropathology, asks how a reflex fails. We will take the arc apart link by link, add the gamma loop that sets its sensitivity, and establish the 2 mechanisms that account for every abnormal reflex you will ever see, interrupting the arc and releasing it. Chapter 9 is the heart of the module, upper versus lower motor neuron lesions. We will define both neurons, contrast their syndromes, cover spinal shock and the abnormalities of tone, add the superficial and special reflexes, and then work through 5 clinical cases. Chapter 10 puts the hammer in your hand, positioning and technique, the NINDS grading scale, the errors that mislead you, and how electrodiagnostics and imaging confirm what your examination predicted. And here is the goal that ties all 3 together. Turn the neuropathology of abnormal reflexes into bedside skill. Localize upper versus lower motor neuron lesions and confirm the level with a precise, well-graded reflex examination. Let's begin with Chapter 8. Chapter 8, Neuropathology. Everything to this point has described the reflex working correctly. Now we study it failing. A reflex fails in exactly 2 ways. and I want you to hold on to this framework because the rest of the module hangs from it. Break the arc itself, and the reflex is lost at that segment. Remove the descending control that restrains the arc, and the reflex is released and exaggerated everywhere below the lesion. Once you understand those two mechanisms, the single most counterintuitive fact in this material becomes obvious: why a lesion in the brain produces more reflex, not less. That is not intuitive the first time you meet it. By the end of this chapter, it will be. Let's work through it. Look at the reflex arc the way an engineer would. 5 components wired in series with no redundancy anywhere in the chain. The muscle spindle and its 1A afferent sense the stretch and carry the signal. The dorsal root and dorsal root ganglion are the sensory entry point into the cord. Within the segment, there is a single synapse, one, not many. The alpha motor neuron, ventral root, and peripheral nerve form the motor limb, and the neuromuscular junction and muscle are the effector. Series wiring with no redundancy has a clinical consequence I want you to say out loud. Any one broken link silences the entire reflex. There is no alternate route. That is why an absent reflex is such a specific finding and such a useful one. Above this segmental circuit sit the descending tracts, and their job is not to trigger the reflex, but to set its gain. The corticospinal and reticulospinal tracts hold the arc under tonic inhibition. This is the break we will return to repeatedly. Spinal interneurons fine-tune the resting sensitivity. So, neuropathology here means a lesion anywhere on this circuit. Break the arc, and the reflex drops. Remove the break, and the reflex climbs. And critically, the site of the lesion dictates which pattern appears. That is the entire basis of localizing a lesion by reflex. This slide answers a question you may not have thought to ask. Why can the same tendon tap produce a different response in the same patient at different moments? The answer is that every muscle receives 2 motor neurons, and they do completely different jobs. The alpha motor neuron is the one you already know. It leaves the ventral horn, travels to the extrafusal fibers, the bulk of the muscle, and it generates force. The gamma motor neuron goes somewhere quite different. It innervates the intrafusal fibers inside the muscle spindle. It produces essentially no force. What it does is set the sensitivity of the sensor. Think of the spindle as a microphone listening for stretch, and gamma drive as the gain control on that microphone. Turn the gain up, and the same whisper of stretch produces a much louder signal in the IA afferent. Turn it down, and the same stretch barely registers. Now, why does this matter mechanically? When a muscle contracts and shortens, the spindle inside it would go slack, and a slack sensor detects nothing. The nervous system prevents this with alpha-gamma coactivation. It fires both together, so as the muscle shortens, the spindle is taken up right along with it, staying taut and responsive throughout the movement. And here is the payoff, the bridge to everything that follows. The descending tracts set the resting gamma drive, the resting gain of the reflex. That is the physiological substrate of the break. When an upper motor neuron lesion removes that descending control, the gain is turned up and left up. The arc itself is unchanged. The sensitivity of the arc is not. That is hyperreflexia, and now you know its mechanism. If you remember one slide from this chapter, make it this one. Every abnormal deep tendon reflex you will encounter arises from one of 2 mechanisms. The first is interrupting the arc. The lesion is in the circuit itself, the afferent limb, the motor neuron, the root, the peripheral nerve, or the muscle. The reflex is diminished or absent, hyporeflexia progressing to areflexia, and the change appears at the level of the lesion, which is precisely why it localizes the affected segment for you. The second is releasing the arc. Here, the circuit is entirely intact. What is damaged is the descending control above it, the corticospinal and reticulospinal systems, the suprasegmental supervision. Now the reflex is exaggerated, hyperreflexia, spread to neighboring muscles, clonus, and the change appears below the level of the lesion because everything downstream has been released. Notice how different those two spatial signatures are. Interrupt the arc and reflexes drop at the lesion. Release it and they surge below it. That single contrast does most of the diagnostic work in this module. Let's take the first mechanism apart, breaking the arc. The mechanism is simple and unforgiving. Interrupt any single link. A monosynaptic reflex has no backup pathway, so one broken link silences it. And because the circuit is segmental, the deficit appears at the segmental level of the lesion. Now walk down the arc and notice that each break has a name: a lesion of the afferent limb, sensory neuropathy, or a dorsal root or ganglion lesion. At the nerve root, radiculopathy, most often from disc herniation, and here is the localizing power, an absent patellar reflex names L4. In the peripheral nerve, polyneuropathy, where the distal reflexes go first, which is why the Achilles is lost before the patellar. At the anterior horn cell, poliomyelitis, and the lower motor neuron component of ALS. And finally, at the neuromuscular junction, or the muscle itself, myasthenia and the myopathies. Around that lost reflex, you will find the rest of the lower motor neuron signature, hypotonia and flaccidity rather than spasticity, neurogenic atrophy, fasciculations, and denervation changes, and weakness in a root or nerve distribution rather than a pyramidal pattern. One broken link, silencing the reflex at its own segment. That is the hallmark of a lower motor neuron lesion. Now the second mechanism, and the one students find genuinely counterintuitive. The mechanism is removal of descending inhibition. The corticospinal and reticulospinal tracts normally restrain the segmental arc, the break. An upper motor neuron lesion lifts that break, and every intact arc below is disinhibited. I want to be precise here because this is a point where many textbooks are loose. The spasticity and hyperreflexia you observe reflect loss of reticulospinal inhibition more than loss of the pyramidal tract itself. A pure, isolated corticospinal lesion produces weakness and a Babinski sign with surprisingly little spasticity. It is the loss of the accompanying descending systems that releases tone. And note where the signs appear, below the level of the lesion, not at it. The cord below the injury is perfectly healthy. It is simply unsupervised. At the bedside, the released reflex declares itself in four ways: responses that are brisk and high in amplitude, spread of the response to neighboring muscle groups, a widened reflexogenic zone where you elicit the reflex beyond the tendon itself, and finally clonus, with the pathological reflexes, Babinski and Hoffman, emerging. The lesion this names is anywhere above the anterior horn cell, cortex or internal capsule in stroke and tumor, brainstem or spinal cord in multiple sclerosis, trauma, and myelopathy. One caution, and we will give it its own slide shortly. Acutely, this is not what you will find. In spinal shock, the picture is areflexic first, and only later hyperreflexic. These three signs are the fingerprints of corticospinal release, and they share one unifying principle worth stating before we take them individually. Clonus first, the released stretch reflex in motion. Apply a quick stretch and hold it, and instead of a single contraction, you get a rhythmic, self-sustaining oscillation. Elicit it at the ankle with a brisk dorsiflexion that keeps the calf under stretch. Interpretation matters here. Sustained, non-fatiguing clonus signifies corticospinal disease, whereas a few beats can occur in normal, anxious, or simply hyperreflexic patients. The Babinski Sign, the plantar response reversed. Stroke the sole, and instead of the toes curling down, you get dorsiflexion of the great toe with fanning of the lesser toes. Here is the elegant part. This is the normal response in infancy, before the corticospinal tract is myelinated. It disappears as that tract matures, and it returns when that tract fails. The Hoffman sign is the upper limb counterpart. Flick the distal phalanx of the middle finger, and you get flexion of the thumb and index finger. It points to a corticospinal lesion, often in the cervical cord. And now the unifying principle. Each of these is a primitive reflex that the developing nervous system learned to suppress through descending control. They are not new pathology being created. They are old behavior being released. Lose the brake, and the primitive pattern returns. This slide is the two mechanisms translated into two clinical profiles. Read it as a matched pair. The upper motor neuron pattern. Reflexes are hyperactive below the lesion with clonus and a brisk spreading response. The accompanying signs are spasticity and increased tone, Babinski and Hoffman, and, importantly, no significant atrophy because the muscle is still innervated. It is simply poorly controlled. The lesion sits in the cortex, internal capsule, brainstem, or cord above the anterior horn cell. The lower motor neuron pattern. Hyporeflexia or areflexia at the segmental level. Flaccidity and decreased tone, and now atrophy and fasciculations because the muscle has genuinely lost its nerve supply. The lesion sits at the root, plexus, peripheral nerve, anterior horn cell, or muscle. Notice that atrophy is doing real diagnostic work in that comparison. Denervated muscle wastes. Disconnected but innervated muscle does not, at least not early. If you want a single sentence to carry out of this chapter, reflexes rise below an upper motor neuron lesion and drop at the level of a lower motor neuron lesion. Final consolidation before we move into Chapter 9. Lower motor neuron lesion. The reflex drops at the level. A break anywhere along the arc produces a segmental deficit, and the lost reflex names the root. An absent patellar means L4. An absent Achilles means S1. The reflex is doing your localization for you. Upper motor neuron lesion. Reflexes rise below the level. Loss of descending inhibition disinhibits every intact arc beneath the lesion. Expect hyperreflexia, clonus, and Babinski. And a practical corollary worth knowing. The first normal reflex level from below marks the lower boundary of the injury. The quick reference by tendon, which you should know cold. Biceps, C5 to C6. Triceps, primarily C7. Patellar, L3 to L4. Achilles, S1 to S2. No excuses for not knowing these. And two principles for every patient. First, the reflex tells you where, not just that. A short, direct arc along a known anatomical pathway localizes the lesion. Second, never read a reflex in isolation. Interpret it alongside tone, strength, sensation, and bilateral comparison. One data point misleads. A consistent pattern localizes. Chapter 9. Lesions of the upper and lower motor neuron. Chapter 8 gave you the mechanism. This chapter gives you the two neurons themselves and the syndromes they produce when they fail. We will define the upper motor neuron, where it begins, the course it takes entirely within the central nervous system, and the largely inhibitory control it exerts over the neuron below it. We will define the lower motor neuron, the final common pathway, the only route any motor command has to reach muscle. Then we will contrast their lesions in detail, the abnormalities of tone, spinal shock, the superficial and special reflexes, and the comparison tables you will meet again on examinations. And we will finish with 5 clinical cases, because this distinction is not learned from a table, it is learned from patients. Take a moment with this diagram because it is the anatomical scaffold for the entire chapter. Follow the upper motor neuron from the top. It begins in the precentral gyrus, the primary motor cortex. Its axon descends through the corona radiata, funnels into the internal capsule, passes through the cerebral peduncle and brainstem, and, for the majority of fibers, decussates in the medulla before continuing down the lateral column of the spinal cord. Every millimeter of that journey is inside the central nervous system. The upper motor neuron never leaves it and never touches muscle. It terminates on the lower motor neuron in a cranial nerve motor nucleus in the brainstem, or in the ventral horn of the cord. From there, follow the lower motor neuron out. Its axon leaves the central nervous system through a ventral root and peripheral nerve, or through a cranial nerve, and travels to the muscle, ending at the neuromuscular junction. 2 neurons, 1 relay point. And that relay point, the anterior horn cell, is the single most important landmark in this module. Everything above it is upper motor neuron. Everything from it outward is lower motor neuron. So when you localize a lesion as UMN or LMN, the question you are really asking is, does this sit above the anterior horn cell or at it and beyond? Keep this image in mind. We are about to hang a great deal of clinical detail on it. Let's be precise about the definition, because precision here prevents confusion later. Upper motor neurons originate in the cerebral cortex, chiefly the precentral gyrus, the primary motor cortex, and in several brainstem nuclei. Their axons form the descending motor pathways, principally the corticospinal and corticobulbar tracts, and they lie entirely within the central nervous system. Now the sentence that matters most. Upper motor neurons never contact muscle directly. They synapse on lower motor neurons, in the cranial nerve nuclei and in the ventral horn of the spinal cord. This is supranuclear control, meaning control exerted above the motor nucleus. And the character of that influence is what makes the whole clinical picture make sense. It is largely inhibitory. The upper motor neuron is continuously restraining the lower motor neuron and the spinal reflex arc. Hold those two facts together. Never touches muscle and largely inhibitory, and the upper motor neuron syndrome writes itself. A lesion cannot denervate muscle, so there is little atrophy. And because it removes restraint rather than command, what you get is too much reflex, not too little. Spasticity, hyperreflexia, clonus, and a positive Babinski sign, all appearing below the level of the lesion. This slide adds a refinement most textbooks gloss over, and it is worth your attention. The cell body sits in the cerebral cortex, chiefly the precentral gyrus. The axon descends entirely within the central nervous system, but it does not descend as one tract. It descends as 2 cooperating systems. The direct system is the pyramidal tracts, corticospinal and corticobulbar. These are the pathways of discrete, fractionated, voluntary movement, the fine control of an individual finger. The indirect system is the extrapyramidal pathways, reticulospinal, vestibulospinal, and rubrospinal. These govern posture, tone, and the background regulation of the reflex arc. Both synapse on and largely inhibit the lower motor neurons of the brainstem and ventral horn. Here is the clinical pearl, and it explains something that would otherwise puzzle you. A lesion in the internal capsule or the cord does not politely damage the pyramidal fibers alone. It removes several descending inhibitory systems at once because they travel together. That is why a UMN lesion produces spasticity and hyperreflexia rather than simple weakness. If only the pyramidal tract were cut, you would see weakness and a Babinski sign with comparatively little spasticity. The tone abnormality is the extrapyramidal loss. Now both neurons on one slide so you can see the handoff. The upper motor neuron descends from the precentral gyrus through the internal capsule and brainstem into the spinal cord. The whole neuron lies within the central nervous system. The lower motor neuron, the alpha motor neuron, comes in two varieties by location. Those with cell bodies in the brainstem, in the cranial nerve motor nuclei, send axons out through a cranial nerve to innervate the skeletal muscle of the head and neck. Those with cell bodies in the ventral horn of the spinal cord send axons out through a spinal nerve to the muscle of the trunk and limbs. That is the final common pathway. Whatever the source of the command, descending from the cortex or generated locally by the reflex arc, it must pass through this neuron to reach muscle. There is no other way out. Which is exactly why the two lesions look nothing alike. A UMN lesion releases the lower motor neuron from inhibition, spasticity, hyperreflexia, positive Babinski, minimal atrophy. And remember, that reflects loss of all the descending systems, not the corticospinal tract alone. An LMN lesion denervates the muscle outright, flaccid weakness, areflexia, marked atrophy, and fasciculations. Let's put the upper motor neuron lesion into examination findings, what you will actually see and feel. The lesion is of the corticospinal pyramidal tracts, sometimes called pyramidal insufficiency, anywhere along the pathway to the cranial nerve motor nuclei or above the anterior horn cell of the cord. Start with muscle performance. There is weakness, but note its distribution because this is a classic examination question. The weakness falls on the extensors in the upper limb and the flexors in the lower limb. That is why the chronic hemiplegic posture is a flexed arm and an extended leg. The stronger groups win. Alongside that, there is decreased control of active movement, particularly slowness. Then tone, spasticity with the clasp knife response, an initial high resistance that suddenly gives way as you continue the movement. Then the release phenomena. The Babinski sign is present, and recall that it is normal in infants up to roughly 2 years until the corticospinal tract myelinates. Hyperreflexia and pronator drift, a sensitive early sign. Ask the patient to hold both arms out, supinated with eyes closed, and the affected arm pronates and drifts downward. The pathologies producing this are the ones you would expect. Anything damaging motor neurons in the brain or spinal cord, stroke, multiple sclerosis, traumatic brain injury, cerebral palsy. This slide exists to keep you from making a serious mistake in an acute setting. Everything we have said predicts that a cord lesion produces hyperreflexia below it. Acutely, that is wrong. Here is what happens. A sudden, severe cord lesion abruptly withdraws all descending drive to the segments below. The result immediately is flaccid paralysis, areflexia, and lost tone below the level, with autonomic collapse alongside it, hypotension, and an atonic bladder. Look at that list. It reads exactly like a lower motor neuron lesion, but the anterior horn cells are entirely intact. They have simply lost every input that kept them excitable. Then it evolves. Over days to weeks, reflexes return and then become exaggerated. Spasticity, hyperreflexia, clonus, and the Babinski sign emerge as the cord reorganizes and the segmental circuitry regains its own excitability without supervision. Return of the bulbocavernosus, or anal, reflex is the classic marker that spinal shock has ended. Why it matters is simple. If you examine a patient in the first hours after a cord injury and localize by reflexes alone, you will call an upper motor neuron lesion a lower motor neuron lesion. In the acute setting, the level of injury is established by the sensory and motor examination, not by reflexes, which have not yet declared themselves. Increased tone is not one finding, it is two, and distinguishing them separates a corticospinal lesion from a basal ganglia disorder at the bedside with your hands in about 10 seconds. Spasticity is the upper motor neuron pattern, and its defining feature is that it is velocity dependent. Move the limb slowly and it feels close to normal. Move it quickly and resistance rises sharply. You will feel the clasp knife phenomenon, a catch, then a sudden give way. It falls preferentially on the anti-gravity muscles, the arm flexors and the leg extensors. And it keeps company with hyperreflexia, clonus, and Babinski. Mechanistically, it follows a combined corticospinal and reticulospinal lesion. Rigidity is the extrapyramidal pattern, and it is velocity independent. Resistance is constant throughout the range and present in both directions, flexion and extension alike. It feels either lead pipe, uniformly stiff, or cogwheel with a ratchety quality when a tremor is superimposed. It affects flexors and extensors about equally. The lesion is in the basal ganglia, Parkinson disease being the obvious example. So here is the practical test. Vary your speed. If resistance changes with velocity, you are feeling spasticity, and you should be hunting for corticospinal signs. If it does not change, you are feeling rigidity, and your differential moves to the basal ganglia. Now the lower motor neuron and its lesion in the same precise terms. Lower motor neurons are the alpha motor neurons whose cell bodies lie in the anterior horn of the spinal cord and in the cranial nerve motor nuclei of the brainstem. Their axons leave the central nervous system through a spinal or cranial nerve to reach and innervate skeletal muscle. They are the final common pathway. Every motor command, descending from upper motor neurons or generated locally by a spinal reflex arc, must pass through this neuron to reach muscle. It drives the muscle directly at the neuromuscular junction, and it sets the muscle's resting tone. A lower motor neuron lesion is injury anywhere along that course: the anterior horn cell, the cranial nerve motor nucleus, the nerve root, the plexus, the peripheral nerve, or the neuromuscular junction. And because the muscle loses its only motor supply, the consequences are direct and severe, appearing in the muscles that neuron serves. Flaccid weakness, hypotonia, hyporeflexia or areflexia, marked atrophy, genuine denervation atrophy, not disuse. Fasciculations, which are the spontaneous discharge of a dying motor unit, and no Babinski sign because there is no corticospinal release. The pathway above is intact. This is the comprehensive comparison, and I would rather you understand the logic of each row than memorize the grid. Location. The UMN lesion is in the central nervous system, cortex, brainstem, corticospinal tracts, spinal cord. The LMN lesion involves the cranial nerve nuclei and nerves, the anterior horn cell, the spinal roots, and the peripheral nerve. Pathology follows from location: stroke, traumatic brain injury, and spinal cord injury on one side, polio, Guillain-Barré, peripheral nerve injury, neuropathy, and radiculopathy on the other. Tone: increased and velocity dependent versus decreased or absent and not velocity dependent. Exactly the distinction we just drew. Reflexes, increased with clonus and a positive Babinski. And note the row that catches people out. The superficial cutaneous reflexes are diminished or absent in a UMN lesion. Deep reflexes rise, superficial reflexes fall. We will give that its own slide shortly. Involuntary movements, flexor or extensor spasms in UMN disease, fasciculations with denervation in LMN disease. Strength. The UMN distribution is never focal. Hemiparesis, paraparesis, quadriparesis. And note the decussation rule. A corticospinal lesion produces contralateral weakness if it lies above the pyramidal decussation in the medulla, and ipsilateral weakness if below it. LMN weakness is ipsilateral and limited, segmental, focal, in a root innervated pattern. Muscle bulk, variable disuse atrophy, widespread, favoring anti-gravity muscles versus rapid, focal, severe neurogenic wasting. This is a useful way to organize the upper motor neuron syndrome, and it comes to us from rehabilitation medicine. Divide the findings into positive and negative signs. Positive signs are things the nervous system is now doing that it should not. Excessive activity at rest, spasticity, spasms, hyperreflexia, primitive reflexes, clonus. Every one of these is a release phenomenon, behavior that was always within the spinal cord's repertoire, previously suppressed by descending control and now unmasked. Negative signs are what the patient has lost, less than normal function. Lack of strength, lack of motor control, lack of coordination. These follow from losing the descending command itself. Why does this division matter clinically? Because the two categories respond to entirely different treatments, and patients and families routinely conflate them. Antispasticity measures address the positive signs. They will not restore strength or dexterity. And it is usually the negative signs, the weakness and the loss of fine control, that are the greater source of disability and the harder problem to solve. So when you evaluate a patient with an upper motor neuron lesion, ask which category is actually driving their functional limitation. The answer determines what will help them. These two reflexes are worth knowing in exact detail because they are asked about with exact detail. The Babinski sign, elicited by stroking the sole of the foot with a blunt object from the heel along the lateral border and across the ball. The positive response is extension, dorsiflexion, of the great toe with fanning of the outer four toes. What it signifies is a corticospinal or pyramidal tract lesion. Note that it is not localized to a spinal segment. It tells you the tract is involved, not where along it. The Hoffman sign, elicited by flicking the fingernail of the third digit. The positive response is flexion of the index finger and flexion with adduction of the thumb. It likewise indicates a corticospinal tract lesion, and it carries an additional locational hint. It is particularly associated with a lesion or contusion of the cervical spinal cord. Two cautions. A Hoffman sign can be present in normal, generally hyperreflexic individuals, so interpret it alongside tone and the other findings rather than in isolation. And asymmetry, here as everywhere in this examination, is far more meaningful than a symmetric bilateral finding. Here is a category of reflex that behaves in the opposite direction from everything else we have discussed, and that opposition is exactly what makes it useful. These are superficial or cutaneous reflexes. You stroke the skin, not the tendon. They are polysynaptic responses to cutaneous stimulation, not monosynaptic stretch reflexes. And their pathway ascends to the cortex and returns, which is why they depend on an intact corticospinal system. They are normally present and they disappear with an upper motor neuron lesion. Say that back to yourself alongside what you already know. In a UMN lesion, deep tendon reflexes rise while superficial reflexes fall. Opposite directions, same lesion. Students lose examination points on this every single year. Know the core three with their levels. The abdominal reflex. Stroke the abdomen toward the umbilicus and watch it deviate toward the stimulus. T8 through T12. The cremasteric. Stroke the inner thigh and the testicle elevates. L1 to L2. The anal wink. Scratch the perianal skin and the sphincter contracts. S2 to S4. They earn their place for two reasons. They are a UMN sign, and because each carries a segmental level, an absent abdominal reflex can help establish a chord level. The anal wink and bulbocavernosus have the additional role we mentioned earlier. Their return marks the end of spinal shock. Beyond the 5 reflexes everyone tests, a few are worth knowing because they answer questions the standard examination cannot. The jaw jerk is the most valuable of these. Both the afferent and efferent limbs travel in the trigeminal nerve, and you elicit it by tapping the chin with the mouth slightly open. Here is why it is powerful. The jaw jerk's arc sits in the pons, above the foramen magnum, above the entire cervical cord. So when a patient has brisk limb reflexes and you need to know whether the lesion is in the neck or higher, this single reflex answers it. A brisk jaw jerk places the lesion above the foramen magnum, implying bilateral corticobulbar involvement. A normal jaw jerk with brisk limb reflexes places it below the neck, cervical cord. That is genuinely useful bedside reasoning, and it costs you 5 seconds. Then 2 release signs involving spread beyond the muscle you struck. The inverted brachioradialis reflex. You tap the brachioradialis, its own jerk is absent, but the fingers flex instead. That combination indicates a lesion at C5 to C6, destroying that segment while releasing C7 to C8 below it. 1 tap, 2 levels of information. And the finger flexor reflex. Brisk finger flexion, Hoffman's cousin, signaling corticospinal release in the upper limb. The general principle to carry: when a reflex spreads to muscles you did not target, you are watching disinhibition. Before we apply all of this to patients, here is a slide to protect you from overcalling pathology. Not every unusual reflex is disease. Start with normal variants. Symmetrically absent ankle jerks are common in the elderly and are frequently normal. Diffusely brisk but symmetric reflexes can also be a normal finding, particularly in anxious or thin young patients. The principle that rescues you in both situations: symmetry reassures, asymmetry demands explanation. Then the metabolic modifiers, which are high yield and satisfying to recognize. Hypothyroidism produces the hung-up reflex, the Woltman sign. You tap the Achilles, the contraction occurs normally, and then the relaxation phase is strikingly slow. The ankle seems to hang before returning. It reflects slowed muscle relaxation, and it is one of those findings that, once seen, is never forgotten. Reflexes are also blunted by hypothermia and by sedative or anticholinergic effects. In the other direction, hyperthyroidism and anxiety speed reflexes up, producing briskness with no structural lesion at all. So the discipline is this: before you interpret a brisk or an absent reflex as localizing disease, ask 2 questions. Is it symmetric? And what else might be modulating this patient's entire nervous system? This diagram is your visual synthesis of everything in this chapter, and it is the bridge into the cases that follow. Study the anatomical map. The corticospinal tract descends from the motor cortex through the internal capsule into the brainstem and down the lateral columns of the cord. A lesion anywhere along that descending pathway, brain, brainstem, or cord above the reflex level, produces upper motor neuron findings below it. The reflex arc itself lives at the spinal segment. A lesion at the anterior horn cell, the ventral root, the dorsal root, or the peripheral nerve breaks the arc at its level and produces lower motor neuron findings at that specific segment. Now trace clinical findings onto the map. A UMN lesion in the brain or cervical cord, hyperreflexia in the lower extremities, Babinski bilaterally, spasticity, because the legs are below the lesion. An LMN lesion at L4, an absent patellar reflex on that side, quadriceps weakness and flaccidity, dermatomal sensory loss. Everything focal, everything at the level. So the question, where is the lesion, reduces to two simpler questions you can answer at the bedside. Are the reflexes up or down? And at what level does the pattern begin? That is clinical neurology. Let's now test it against real patients. 3 patients, 3 mechanisms. Reason through each one before I give you the localization. Case 1. A 65-year-old man with acute left hemiparesis noted on waking. Reflexes are brisk below the lesion level, tone is increased, there is a positive Babinski sign, and the sensory changes are variable. Localization, above the arc. Descending inhibition has been lost, and every intact reflex arc below the damaged pathway is released. Case 2. A 42-year-old woman with radiating leg pain after lifting. The patellar reflex is absent. There is quadriceps weakness in the L4 myotome, decreased tone, and dermatomal sensory loss over the medial leg. Localization, at the arc. One segment is broken, and the deficit maps precisely to L4. Notice how much anatomy a single absent reflex just handed you. Case 3. A 58-year-old man with 6 months of bilateral foot numbness and tingling. Reflexes are globally diminished, the Achilles absent first, with glove and stocking sensory loss in a symmetric, length-dependent pattern. Localization beyond the arc. This is not one broken segment, it is many nerves diseased along their length, the longest fibers failing first. 3 levels, 3 patterns, 3 mechanisms. And the reflex examination sorted them. UMN goes up, LMN goes down at the level. Neuropathy goes down everywhere, distally first. 2 more patients, chosen because they sit at opposite extremes of the spectrum. Case 4. A 45-year-old woman with ascending weakness over 5 days. The Achilles and patellar reflexes are absent bilaterally. There is symmetric, flaccid weakness and stocking glove sensory loss. The mechanism is Guillain-Barré syndrome, autoimmune demyelination of peripheral nerves. Once myelin fails, the IA afferents and the motor axons cannot conduct, and the arc is interrupted bilaterally. Note the pattern, symmetric areflexia from diffuse lower motor neuron disease, not a focal lesion. And note the urgency. Ascending weakness with areflexia is a neurological emergency because the diaphragm may be next. Case 5. A 30-year-old woman with episodic vision loss and hand numbness. Reflexes are brisk bilaterally with a positive Babinski bilaterally and no acute weakness at all. The mechanism is multiple sclerosis with demyelinating plaques in both corticospinal tracts producing bilateral loss of descending inhibition. Upgoing toes without overt weakness. That last point deserves emphasis. Upper motor neuron signs can precede clinically obvious weakness. A patient who feels essentially well can carry unmistakable corticospinal findings on your examination, which is the whole argument for examining reflexes carefully in every patient, including the ones who look fine. The key insight across both cases: brisk, exaggerated reflexes localize above the arc. Absent reflexes point to the lower motor neuron or the peripheral nerve. This table is your board preparation summary, and I want to walk the rows that are most often tested. Weakness pattern. Pyramidal weakness involves a whole limb or a whole side, hemiparesis, paraparesis, quadriparesis, with arm extensors and leg flexors weakest. LMN weakness is focal, confined to the myotome or the nerve supplied. Tone. Increased, spastic, velocity-dependent with clasp knife giveaway versus decreased, flaccid, hypotonic. Deep tendon reflexes. Hyperreflexia, brisk, and spreading, with the acute caveat we covered that they may be reduced during spinal shock, versus hyporeflexia or areflexia at the segment. The localizing rule, which is the single most useful line on this slide: reflexes rise below a UMN lesion. The reflex drops at the level of an LMN lesion, and the lost reflex names the root. Plantar response: extensor, Babinski, present, versus flexor or absent. Muscle bulk: preserved, with only mild late disuse atrophy versus marked early denervation atrophy. And fasciculations, with fibrillations on EMG, are the electrophysiological hallmark of denervation. One asterisk worth remembering: ALS shows both upper and lower motor neuron signs simultaneously. A patient with brisk reflexes in a wasted fasciculating limb is showing you both at once, and that combination should immediately raise motor neuron disease in your mind. The board pearl in a single line: a UMN lesion releases the cord, an LMN lesion denervates the muscle. Chapter 10. The Clinical Examination. Everything so far has been interpretation. This chapter is execution. And I want to be direct about why it deserves a chapter of its own. An unreliable examination produces unreliable data, and unreliable data localizes nothing. Most of the errors I see in reflex testing are not errors of knowledge. They are errors of technique. We will cover positioning and hammer technique, the reinforcement maneuvers, and bilateral comparison. We will walk the examination protocol step by step. We will formalize grading with the NINDS myotatic reflex scale, the board standard. We will name the 4 errors that most often mislead. And we will close the loop from the bedside to the workup, showing how electrodiagnostics and imaging confirm what your examination predicted. This is where knowledge becomes skill. 4 pillars of proper technique. Each one exists because getting it wrong produces a specific, predictable false finding. Patient positioning: why it matters. Voluntary muscle contraction suppresses the stretch reflex, so a tense or anxious patient can produce false hyporeflexia that mimics neuropathy or radiculopathy. What to do? Muscles fully relaxed, limbs fully supported, legs hanging freely for the patellar. For the Achilles, place the foot in slight dorsiflexion, which pretensions the tendon and makes the response more reliable. Reflex hammer technique: why it matters. Inconsistent force or the wrong strike site produces unreliable grading and false asymmetry. What to do? Swing from the wrist, not the elbow. The force comes from a pendulum swing, not a thrust. Strike the tendon, not the muscle belly, and use equal force on both sides because you are about to compare them. Reinforcement: why it matters. This is how you distinguish a truly absent reflex from a merely suppressed one. What to do? The Gendrasic maneuver for the lower limbs. The patient interlocks the fingers and pulls apart while you test. For the upper limbs, have them clench the teeth or count aloud. And the physiology is exactly what we covered with the gamma loop. Reinforcement raises motor drive and removes cortical suppression, turning the gain back up. Always document that you used it. Bilateral comparison. Why it matters. Asymmetry is often more diagnostically valuable than the absolute grade. Test the same reflex on both sides before moving on. Grade each side independently and never assume symmetry. Here is the protocol in 5 steps. The sequence I want you to run every time until it is automatic. Step 1. Position the patient. Muscles relaxed, joint in a neutral position. Optimal positioning is not a nicety. It is the precondition for a valid result. Step 2. Position yourself. This step is routinely neglected. The clinician must also be relaxed and properly positioned. You need a clear swing at the tendon and a clear view of the muscle you are watching. If you are reaching awkwardly across a bed rail, your force will be inconsistent and so will your findings. Step 3. Ensure muscle relaxation. The muscle being tested must be genuinely relaxed. A tense muscle dampens or eliminates the response. Watch it and palpate it. Do not assume. Step 4. Stroke for rebound. Hold the hammer loosely between thumb and index finger and let it swing freely from the wrist. Here is the key principle and the phrase I want you to carry. Stroke. Do not chop, hammer, or strike forcefully. Force does not produce a better reflex. It produces a guarded patient. Step 5. Find the maximum response, then compare bilaterally. Search for the site of maximum response, then test the opposite side the same way. Any asymmetry must be corroborated with the patient's other symptoms and signs. And the pearl at the bottom is the objective of the entire exercise. What you are looking for is symmetry. A generalized change has limited value on its own. A localized asymmetry points to the level, hyperactivity suggesting UMN involvement, depression suggesting LMN. Now let's formalize grading, because if you and I examine the same patient, we should record the same number. This is the NINDS myotatic reflex scale, proposed by the National Institute of Neurological Disorders and Stroke in 1993 and validated for inter-rater reliability. It runs 0 to 4, and this is the scale to know for board examinations. Grade 0, the reflex is absent, no response. Grade 1, small, less than normal, a trace response, or one elicited only with reinforcement, the Gendrasic maneuver. Grade 2, in the lower half of the normal range. Grade 3, in the upper half of the normal range. Grade 4, enhanced, more than normal, and this includes clonus if present, which may be noted separately in your description. 2 points of practical guidance. First, notice that grades 2 and 3 are both normal. A 3 is not automatically pathological. It is simply the upper half of normal. What makes a 3 meaningful is context, asymmetry, or accompanying spasticity, and a Babinski sign. Second, you will hear clinicians use the older Wechsler shorthand, 0 to 5 plus, where 5 plus denotes sustained clomis. It describes the same phenomena with a different ruler. Know both, chart in one, and label which one you are using. And whichever scale you use, grade each side independently and use reinforcement before you ever record a 0. Before we finish the examination section, I want to point you toward a companion resource that extends what we have just covered. On your screen is the link to my instructional video, the Deep Tendon Reflex Exam, the complete upper and lower extremity guide, available on my YouTube channel. This lecture has given you the neuroanatomy, the neurophysiology, and the interpretation framework. The video shows you the hands-on technique in a real clinical setting. You will see proper patient positioning, exactly where to place the hammer, how to strike with consistent force, how to use the Gendrasic maneuver, and how to grade and compare side to side, performed on an actual patient. Reading about reflex technique and watching it performed are two different kinds of learning, and they reinforce each other. Use both. The video is free, it is focused, and it will accelerate your competency at the bedside considerably faster than text alone. Find it on YouTube. Search Dr. Timothy Conwell Deep Tendon Reflex Exam, or follow the link below. 4 errors account for most of the unreliable reflex examinations I see. Each has a consequence, and each has a fix. Error 1. The patient is not relaxed. The consequence is false hyporeflexia, which can trigger an entirely unnecessary workup for neuropathy or radiculopathy. The fix. Support the limb, let the muscles go completely slack, distract the patient, or use the Gendrasic maneuver, and retest once you have confirmed relaxation. Error 2. The wrong strike location. The consequence is a weak or absent response, a falsely low grade recorded for a reflex that is entirely normal. The fix. Palpate the tendon first, then strike directly over it. Swing from the wrist. Use equal, consistent force on both sides. Error 3. Not comparing sides. The consequence is that focal lesions are missed. A unilateral radiculopathy looks perfectly normal if you only test one side. The fix? Test the same reflex bilaterally before moving on. Record left and right separately, and remember that asymmetry outweighs the absolute grade. Error 4. Overinterpreting a single reflex. The consequence is premature localization. One brisk reflex without supporting findings can send you down entirely the wrong path. The fix. Corroborate with tone, strength, and sensation. Look for a consistent pattern rather than a single data point, and retest before you document an unexpected finding. And the bedside self-check. Is the patient relaxed? Am I striking the tendon? Did I compare both sides? Does the pattern fit the tone, strength, and sensation? Those 4 questions will prevent the large majority of errors. Your examination generates a hypothesis. This slide is how that hypothesis gets confirmed. If you suspect a lower motor neuron lesion, the confirmatory tests are electrodiagnostic. Electromyography shows fibrillations and positive sharp waves, the electrical signature of active denervation. Fasciculations and reduced recruitment support anterior horn cell or nerve disease. And nerve conduction studies localize and grade a peripheral neuropathy, distinguishing a demyelinating from an axonal pattern. If you suspect an upper motor neuron lesion, you image the central pathway. MRI of the brain and cord finds the lesion, the stroke, the multiple sclerosis plaque, the tumor, the compressive myelopathy. And here is the relationship I want you to hold on to. The examination predicts the level. Imaging confirms where to look. That order matters, both intellectually and practically. A well-performed reflex examination tells the radiologist which segment to scrutinize. Imaging the entire neuraxis because the examination was imprecise is slower, costlier, and far more likely to turn up incidental findings that mislead everyone involved. So the loop closes like this. The examination localizes, the study confirms, and the two together make the diagnosis. Neither one replaces the other. We have covered a great deal today. Let me consolidate it into the 6 concepts you should carry into every clinical encounter. 1. The reflex arc. Monosynaptic, muscle spindle, 1A afferent, 1 synapse, alpha motor neuron, contraction. 1A fibers monitor length. 1B fibers from the Golgi tendon organ monitor tension. The corticospinal and reticulospinal tracts provide tonic inhibition. Lose the brake, and the reflex is released. 2. Upper versus lower motor neuron. UMN stroke, MS, cord compression, hyperreflexia, spasticity, Babinski, no early atrophy with deficits below the lesion, LMN, radiculopathy, Guillain-Barré, hyporeflexia, flaccidity, fasciculations, atrophy with the deficit at the level. The mnemonic, UMN, everything up, LMN, everything down. 3. Grading. The NINDS scale, 0 to 4, is the board standard, and 2 and 3 are both within normal. Asymmetry outweighs the absolute grade, and use reinforcement before recording a 0. 4. The localization framework. Above the arc, UMN, hyperreflexia below the lesion. At the arc, root or LMN, focal hyporeflexia naming the segment. Beyond the arc, neuropathy, symmetric and distal first, Achilles lost first. 5. The reflexes and their roots. Biceps C5 to C6, brachioradialis C5 to C6, triceps primarily C7, patellar L3 to L4, Achilles S1 to S2. 6. Technique. Patient relaxed and supported. Strike the tendon, swing from the wrist. Always compare bilaterally and corroborate with tone, strength, and sensation before you localize. The bottom line, know the arc, grade it accurately, compare both sides, and let the pattern tell you where the lesion is. Before we close, let me leave you with 3 things. First, if this series reinforced the value of a rigorous, systematic approach to the neurological examination, I want you to know about a resource that takes that approach much further. The Clinical Picture, Essentials of the Neuromusculoskeletal Exam, is a comprehensive clinical reference covering the complete neuromusculoskeletal workup, the history, the physical examination, neurological and orthopedic evaluation, clinical case studies, and full documentation, including narrative reports and SOAP charting. It is the only text that takes you from examination findings all the way through to a finished clinical record in a single, concise volume. Whether you are preparing for board examinations, entering your clinical rotations, or you simply want a reference that translates neuroscience into practical documentation, this textbook belongs on your desk. It is available now on Amazon. The link is on your screen and in the description below. Second, put today's material to the test. This module includes a complimentary board preparation flashcard set, 80 board-style examination questions, each with a detailed explanation and rationale. Available now at theclinicalpicture.com/lecture series. This module went deep, and it earned the extra questions. And here's my challenge to you. Don't just read the answers. Reason through each question first, and then reveal the explanation. That process of active recall is one of the most powerful ways to strengthen retention, sharpen your clinical reasoning, and build the confidence you will need on your boards and with the patients you will care for throughout your career. And third, this completes our 3-part series on the deep tendon reflexes. Consider how far you have come. In Module 1, the reflex was an anatomical circuit. In Module 2, it became a physiological signal you could grade. And today, it became a diagnostic instrument, a way to answer the question every neurological examination is really asking: where is the lesion? You now hold a skill that requires no technology, costs nothing, takes 90 seconds, and localizes disease within the nervous system. Use it on every patient. If this lecture deepened your understanding of this important clinical topic, please subscribe, like, or leave a comment below. It genuinely helps me produce more content like this. Thank you for watching.